this is a question from Dr. Wariak. Sorry if I pronounce it wrong. Do you often do the enteric tubes like nasal jejunal tube or PJ in pediatric? Can you tell us about their indication and interest in pediatrics?
Oh, we just did it last week. We have sometimes there are patients who have esophageal strictures or who have gastroesophageal reflux, okay, and with an existing gastrostomy tube, and the patient is too frail, not very healthy, so cannot undergo a major surgery. So for those patients, we just thread the G tube through the pylorus down into the jejunum. So that means we feed directly into the jejunum, so the reflux is lessened, it's very much lessened.
So thank you. So another question to Professor Sakyus. This is the slide is quite similar. So which one you prefer, or which group of patients that you prefer to select to do laparoscopic gastrostomy tube or do the endoscopic? Because now both of them have low complication compared to the open gastrostomy.
I have done the cost benefit analysis. And it's actually cheaper to do the endoscopic gastrostomy tube placement. So, but as far as choosing the preference, it's really a matter of indication and the indication of doing the gastrostomy. If there is another procedure topically, but if you have just a gastrostomy, then definitely endoscopic is easier. It's also faster, less resources are needed.
Okay, thank you. So this is for Professor Rai. Do you, in terms of IBD patients, that sometimes we know that sometimes it has stricture. So when we consider to use the capsule, do we need imaging every time? The imaging, do we need to do the imaging to rule out the stricture every time? Can you comment on that?
Yeah, actually, imaging study, like my barium study with small bowel follow through, even though you feel like, it's not stenotic by small bowel follow through, but I had two patients actually who stuck, with patency capsule. So as far as you think this is not a real structure, you can just try patency capsule. Some people get some stuck, it can get stuck, in some patients you may have to place some NG or ileus tube, but most of the times, even it happens after 2 days, it gets dissolved and patient should be fine. So if you feel like, this patient's serious small intestinal disease, which you like to evaluate, and you try to start capsule endoscopy from patency capsule, which shouldn't be too risky for the patient. So imaging studies such as MRCP, CAT scan, or barium study may not be reliable in order to exclude, this patient may retain the real capsule. So patency capsule is always a way to go. Okay.
Okay, so this is just continue the next question. So in terms of you have experience in both capsule and a small bowel endoscopy, which one do you prefer? In case, for example, you see the patient, that which indication you prefer, a small bowel first, a small bowel endoscopy first, or which indication you prefer the capsule first?
Yeah, less invasion, is things we have to prioritize for the patient. So we always start from capsule endoscopy, and if we feel like this is a significant lesion, but we don't have diagnosis for this patient, say you have some like after ulcers, in the colon or some duodenum, but you don't know if this is a real Crohn's disease or not, and if you see some lesions in the small intestine, in order to confirm the diagnosis, you may want to do small bowel, enteroscopy and balloon enteroscopy, or if you have reason to do it, say patient has stenosis, you have to dilate it, or patient seems to be having some bleeding, so you like to stop it. Those are the times we go for the enteroscopy. So usually we don't want to do too much, endoscopy for children. So always start from capsule endoscopy. Then only if, there's some reason stenosis capsule cannot, be used because of the stenosis or some intervention is required. Those are the times we really think, balloon-assisted endoscopy is important for IBD patients.
Thank you. So this another question from Dr. Arani Widodo in our on-site. So this for Professor Sakirogen. What is the smallest and youngest safe age for the push technique? Because it needs to be 3 points that you have to mark, right? So what is the youngest age that you able to do this procedure?
I was only able to do it in a 1-year-old, around 10 kilograms. Okay, so actually the more pressing problem for us is finding having the endoscope, the pediatric endoscope. Okay, so not many institutions in the Philippines are properly equipped to do the push technique, unfortunately.
So that means if you have the set, that means the youngest age, the lower.
I can do it as just a 6
Yeah.
months.
Oh, okay. Thank you. So this is another question for Professor Kim. What the size are you using for ERCP in children?
Thank you for your question. Usually, I do ERCP for children over 12 months, 1 year, over 10 kilogram. And actually, I previously used the PJF, which was used for such a small baby. But in the case, we couldn't do a therapeutic procedure freely. So we do not use PJF nowadays in our center. Instead, we usually use JF, maybe around 11 millimeter diameter, which can be used for children over 10 kilogram, over age 12 months.
Okay, this is another for my interest. Very interesting. What is your opinion in? Can you make a comment in using ERCP as one of the tool for diagnosis of the biliary atresia?
Actually, I tried that before when I was 20 years ago. At that time, PJF was not that excellent. Anyway, the cannulation was very difficult, and we have to do under general anesthesia. But nowadays, there's a lot of MRCP and biopsy, which is much safer than ERCP. So I didn't use that again. So I don't agree with ERCP can be used for biliary atresia for general hospital. In selected, there has experienced pediatric ERCP doctor. In selected case, they can use that, but I don't think it's not that useful for neonatal cholestasis.
Okay, thank you so much, for very informative answer and also lecture today. So now due to the time constraint, we are a little bit late. So now we have to move on to the next session, and we will have 10-minute breaks before coming back into the last section, which is very interesting, more interesting topic going on. So don't forget to help us to evaluate by scanning the QR code and evaluate us and send it back. And also some people that cannot attend all the session, we also have the rerun session in a few weeks that we can follow on afterward. Thank you so much.